Again, I'm Dr. Victor Awuor. I'm a neurosurgeon at Ohio Health Grant Medical Center. I'm going to talk about the principles and techniques of the management of upper cervical trauma. So it's really going to be upper cervical trauma, and then talk just a little bit on critical care of the brain, neurocritical care of the brain. Um, Now, the treatment of the occipital cervical junction and upper cervical spine traumas, it carries great importance. In this area, you have unique form of bones. These are you have some atypical bones. You have complex ligamentous structures, and also you have complex neurovascular structures. And the occipital cervical junction is from the occiput to the C2-3 disc. The important structure here is that transverse ligament. The transverse ligament is very important for providing integrity, support in this area, and the axis is going to rotate on the atlas. The dens is a pivot for that atlas to rotate around on the axis. And these are, again, atypical vertebrae. And another important structure in this area is going to be the vertebral arteries. It's important to understand the course of the vertebral artery as it goes through the transverse foramen, loops around the posterior arch of C1, and then goes intradurally. Classification of injuries in this area, there's going to be ligamentous, there's going to be isolated bone fractures, and then mixed ligamentous and bone injuries. Now, I'm going to go pretty fast just to make up for some of the time here. So I'm going to skip several slides. So we will be going rather fast through this through these slides. So there's different types of injuries that we're going to discuss. We're going to talk about occipital condyle fractures, atlanto-occipital dislocations, atlas fractures, odontoid fractures, hangman's fractures, combined C1, C2 fractures. Now I'm going to address this the combined C1, C2 fractures right now. The main thing that you need to know about these is that if you have a surgical C1, C2, combined C1, C2 fracture, you address it like you would address the C2 component, and that will address the C1 aspect of it. So when you have a combined fracture, address it as how you would address the C2 fracture. Then atlantoaxial dislocations as well. So we have a 68-year-old female, presents with neck pain after a riding mower accident, and she's neurologically intact and has this fracture here. So what we see here is we have bilateral occipital condyle fractures, and then also you have an atlanto-occipital dislocation. As you can see there, the atlanto-occipital interval is greater than 2 millimeters. The space between the occipital condyle and the atlas should be less than 2 millimeters in adults. And in this case, it looks like you have several millimeters there. So you not only have occipital condyle fractures, you also have OC dislocation. So for this here, the treatment will be on occipital cervical fusion. The Anderson and Montesano classification here will, I'll skip that for now. Remember that atlanto-occipital interval should be less than 2 millimeters. And you can see there with that dot just underneath the occipital condyle, that space should be less than 2 millimeters in adults. In pediatric patients, it's less than 5 millimeters. So if someone has an occipital condyle fracture, and there is evidence of ligamentous injury or instability, those are the patients that we do occipital cervical fusions on, or you can treat them in a halo. Usually we will do an occipital cervical fusion in those particular patients. Most other fractures are going to be treated in a collar. And if you have bilateral occipital condyle fractures, you can consider halo vest to provide increased immobilization. Here's another patient, 55-year-old female, who presents after a motor vehicle accident with severe neck pain. What you have here is a unilateral ring fracture. You can see that we do have fractures through both the anterior and posterior arch of C1, but it's on one side, so it's a unilateral ring fracture. And the key to treatment, to the treatment of these kinds of injuries is determining the integrity of the transverse ligament, okay? If the transverse ligament is disrupted, then surgical intervention is what we will typically recommend. So in this particular case, you can see the significance of the displacement. So for this patient, I would recommend surgery. Now, you do not have to go to the occiput for a unilateral ring fracture, so keep that in mind. For these unilateral ring fractures, a C1, C2 fixation will suffice. And this is how we would treat this particular fracture. Here is another patient. Now, this is the classic Jefferson fracture where you have a 4-point Jefferson fracture, or what we consider a burst fracture of C1. So a 45-year-old male who's involved in a motor vehicle accident, patient's neurologically intact. But again, with these patients, I'm not going to show the MRI, but we typically get MRIs. In this particular patient, considering the extent of the displacement, you can see the transverse ligament is compromised. So just take my word for it on that one. So when you have this kind of injury, then the fixation is going to be an occipital cervical fixation. A C1, C2 fusion will not suffice for that. These are the different kinds of atlas fractures. So you see the type 1 fractures, it's just one ring is involved. Once we get to type 2 fractures, we have you have more than one arch, rather. So in type 1 fractures, one arch is involved. In type 2 fractures, you have more than one arch involved. And then in type 3, you have a comminution, you have a fracture of the lateral mass in that instance. So this is the important slide here as far as treatment, okay? So the integrity of the transverse ligament is going to be the most important determinant of stability. So that's the key thing that you need to know right there. If the transverse ligament is intact, then cervical immobilization will suffice. If the transverse ligament is disrupted, then the treatment would either be cervical immobilization or surgical fixation. And if you have a unilateral ring or just an anterior C1 arch fracture, then a C1, C2 fusion will suffice. If you have multiple ring fractures, like the classic Jefferson burst fracture, then it is important to go to the occiput. What are the options for C1, C2 fusion? You can do the C1, C2 transarticular facet screws. I used to do these, but I've kind of shied away from them. Just your risk for a vascular injury is higher. Our workhorse really at Grant now is the Harms procedure, doing the C1, C2 lateral mass, doing the C1 lateral mass and C2 pedicle screws. That's really been our go-to. Then there's also wiring. At our institution, we've almost completely gone away from wiring. Years back, maybe we would have a few situations of wiring, but now with navigation, we've gone almost completely away from C1, C2 wiring. So now, if you're going to do a transarticular facet screw, again, the major risk is vascular injury. You want to start 1 to 2 millimeters superior to the C2-3 facet on the midline axis of the pars, and then you use a drill guide through a separate incision, and keep the drill far dorsally as possible within the pars, and then put the screw through the same path. Now, again, at our institution, when I'm doing a transarticular screw, you can see here is one of my cases where I'm using navigation. So, I've really gone away from using too much X-ray, and I'm really very much dependent on the OR. And remember, the key is your navigation is only as good as it is accurate. So we have various ways of continuing to test for accuracy as we do these procedures. If you're doing this, if you're doing C1, C2 screws, then your entry point usually is the midpoint of the inferior part of the lateral mass, and your target is going to be the superior portion. On your lateral fluoroscopy, you're going to be aiming for the superior portion of the anterior tubercle of C1. And for C2 pedicle screws, you're going to start 3 to 4 millimeters above the inferior margin of the C2 inferior facet at the midpoint of the facet. And you're going to aim 20 to 30 degrees medially and 25 degrees superiorly. I have a hard time with degrees, all these numbers. So I know what a 45-degree angle looks like. So for all my angles, if I were not using fluoroscopy to do this, everything's going for this. Mine is going to be. I put my hand out 45 degrees, and then I just half that, and that's going to be the what I'm going to use both for my medial and superior angulation of these screws. So 45-degree angle is something that's easy to quickly know, and then to adjust to half of that. Again, this is showing the entry point. Now, when you're using navigation, these entry points don't matter as much. Of course, it's important to know them and be familiar with them. But when you're using navigation, the key is put the screw in the bone and make it bicortical and stay away from the important stuff. Stay away from the vessels, stay away from the nerves. So pretty much put the longest screw you can possible and try and get it bicortical if you can and stay in the bone. So having that in mind, navigation makes these surgeries so much simpler. I remember, in training, C1, C2 screws, everyone used to avoid these C1 screws because of the amount of bleeding you'd have. And so a lot of patients would get an occipital cervical fusion who because we were avoiding the blood loss. And it was just tenuous to do these surgeries. But with navigation now, I would say our blood loss with these C1, C2 kinds of surgeries is anywhere from 50 mLs. A case that you really lost a lot, maybe we're looking at 250, 300 mLs. That's like a case that you had a lot of blood loss. So we're not losing that much blood in these cases anymore. But nonetheless, if you're using X-ray, again, look at these. Your starting points. That midpoint of that inferior facet is going to be your entry point. The literature says 17 degrees medially. Like I said, when I'm doing these, I don't know what I wouldn't know where to put my hand to 17 degrees. I wouldn't know what a 22-degree looks like. So what I do is go 45 degrees. That's what I'm familiar with. I know what a 45-degree angle looks like. I half that, and that will give you a good screw. So that's usually what I do. Again, just showing different techniques of putting these screws. So with lateral mass screws, there's different techniques. There's the Magro, Roy Camille, Anderson techniques, so I don't like degrees. I don't. So what my technique is, we will find the midpoint of that lateral mass. We'll go 1 millimeter medial and 1 millimeter superiorly, and then just aim for the superior the upper outer corner of the lateral mass. That will get you the perfect screw every time. It will look like a Rob Galler screw that we saw in those images. So if you want the Rob Galler screw, but you're degree challenged, then you want to start 1 millimeter medial, 1 millimeter superior, and then just aim for the superior, that upper outer corner of the lateral mass, and you'll get the perfect screw every time. The best thing that ever happened to upper cervical spine surgery is navigation. I love this stuff. I love technology. I love navigation. We use this so much. We've gotten pretty efficient with using this machine. Whenever you start with new technology, there's definitely, you feel like it's slowing you down. But I mean, this stuff has increased efficiency, has has decreased our surgical time significantly, decreased blood loss, better outcomes, better accuracy, and surgeries now, like a C1, C2 fixation is typically probably a 45 to 1 hour surgery at the most. So typically about 45 minutes or so. Now, positioning for these patients. Now, we've gone, we've gone away from using the Mayfield in a lot of our surgeries, even our posterior cervical fixations. We just put patients on a Jackson table with a prone view. It keeps them really nice and neutral. This is my dedicated PA because I did not take a picture in the operating room. If you ever need an OR model, the name is Sarah Dick. She will help you get the best positioning pictures. As you can see, very dedicated PA. So anyways, she's not on the prone view, but that's the position typically for my posterior cervicals and also for my C1, my occipital cervical junction type surgeries. But now when I'm going to the occiput, I'll put patients in a Mayfield just so I can flex them some. But I rarely go to the occiput, so most of the time we just put patients in a prone view. So this is my technique of how we do these surgeries. We position the patients just like I mentioned, and then we obtain a lateral X-ray. The stealth frame is then attached on a Mayfield. If you're using a Mayfield, you can put it on a Mayfield. You can attach the stealth frame on a Mayfield, but we rarely use a Mayfield anymore. So I usually attach the stealth reference frame on C2. Then you expose, obviously you're going to expose the C1, C2 complex, and the bleeding is controlled with bipolar and flow seal. And then we use these, the mini screws, the CMF screws. I use the small cranial fixation screws. I'll put one on one arch, on C1, the C1 arch, the posterior arch, and then the second one I'll put on the C2 lamina on the opposite side. So I have 2 points where I can reference my navigation just to make sure that it's accurate. We do an O-arm spin, and then you check the instruments for accuracy. This is key. Checking your instruments for accuracy is going to be key to making sure that everything is on point as far as accuracy and making sure that you don't harm the patient. We then retract the C2 nerve inferiorly with a suction nerve retractor. And then a high-speed drill that with a 3mm matchstick is used to drill to about 6mm into the lateral mass. And then after you've just decorticated and then gone in 6mm, we go straight to the screw. For the C1 screw, 99% of the time, I'm going to put a 3.5 by 34mm partially threaded screw, and that just gets navigated till it's bicortical. And so I don't use a separate drill. Once we start off with a high-speed drill, we go straight to the screw, and that you're skipping. It allows you to have very few steps, so you're in and out. Blood loss is minimal, and you want to leave. You want that 34mm screw because you want it to sit a little bit proud, so that it lines up with your C2 screw. And then we put C2 screws in a similar way. The C2 screw is also, you just drill about 6mm again into C2 and then go straight to the screw. And then if you want to if you're arthrodesing, then you just arthrodese the posterior elements and place some allograft bone. So here's a 35-year-old male who was involved in a motor vehicle accident. Patient was intubated at the scene, did have some cardiac arrest, and then underwent CPR. Patient now opens their eyes to commands, has 2 out of 5 bilateral upper and lower extremity strength. Cervical collar is in place. So if you look here at this particular patient, you can see that the Bayesian dental interval is significantly increased. So this patient has occipital cervical dislocation, and you do not want to put you want to take that collar off and put the patient in sandbags, because putting them in a collar can actually displace this further. And the treatment for this would be occipital cervical fixation. Now, there's certain ways to determine atlanto-occipital dislocation, certain numbers. You have the Powers ratio, you have basiodental interval, but what we'll do is, and there's different classifications. The Trinellus classification here, it's pretty simple. Type 1, you can see that the occiput is translated anteriorly. Type 2 is a longitudinal dislocation, and then type 3 is a posterior dislocation. This is going to be really a good way to determine the dislocations just by looking at CT. So the Bayesian axial interval. The Bayesian axial interval is the distance from the Bayesian to the rostral extension of the posterior axial line. So this should be less than 12 millimeters. And this is better for anterior and posterior dislocations. But this should be less than 12 millimeters and is a very good way of assessing anterior and posterior dislocations. For longitudinal dislocations, the Bayesian dental interval is going to be the key. And this is easy to remember because both of them need to be less than 12. The Powers ratio is not as reliable, so I would not use that. I do not use it at all. So again, the most sensitive method for diagnosis of atlanto-occipital dislocation was, in this study, is measurement of the Bayesian axial and Bayesian dental interval on CT scan. And cranial cervical fixation with internal fixation is recommended for the treatment of dislocation. You have a 70-year-old independent male with a past medical history of prostate cancer who's sent to the hospital by his PCP because of complaints of severe neck pain after a fall. I don't know how well you can see this, but this patient has a non-displaced type 2 odontoid fracture. So what is the treatment for this patient? Odontoid screw or C1, C2 fixation. And as long as the transverse ligament is intact, then this is an option for this patient. Now, this is a odontoid screw that we put in under stealth neuronavigation, and you can see that you can put these screws very well with stealth and very accurately. And this is the setup in the OR. Now, these patients are in a Mayfield, and the stealth reference frame is put on the Mayfield. As you can see, if you look at C3, you'll see that I have one of those small CMF screws. That is just used as a reference for the navigation, so just to test your accuracy, because that is a very tiny screw. You want to test all your instruments on that just to make sure that everything is accurate. And this is what we have here after screw fixation. Now, with odontoid fractures, flexion is the most common mechanism. Patients usually have neck pain. There's different types. Now, I'll go over the management of odontoid fractures. For type 2, the surgery is recommended for type 2 if their age is greater than 50. So if you have a non-displaced odontoid fracture and the patient's age is over 50, then typically these patients will develop a non-union and develop this, and typically will progress to displacement. So you want to fixate these patients. Now, a type 2A, that's when there's comminution of the fracture. Those surgical interventions also recommended. And then there's type 2 and type 3, which are displaced more than 5 millimeters. You want to fixate those. And then a progression of a fracture in external immobilization. So, some of these patients, let's say they're younger than 50. You have a 30-year-old or something with a non-displaced odontoid fracture. You put them in a collar, and on follow-up, you see that there is definitely progression of the fracture, and they're starting to listhese. It's greater than 5 millimeters. Then fixation would be the way to go. Then if you're going to treat them non-surgically, usually 10 to 12 weeks with an external immobilizer. So surgical options, again, the odontoid screw is an option if the transverse ligament is intact. So that's important. You should evaluate these patients with an MRI just to assess the integrity of the transverse ligament. And then C1, C2 fusion, there's options. You can do the C1, C2 transarticular screw, which like I said, I have gone away from. And then there's C1, C2 stabilization with, you can do the Harms technique or wiring, which I have also gone away from. So my go-to is typically, if we're going to do a posterior approach, it's going to be the C1, C2 Harms procedure. Here we have an 80-year-old female with a history of mitral valve regurgitation, hypertension, and GERD who presents with severe neck pain, right upper extremity weakness, weakness and tingling. We have 4 out of 5 right upper extremity strength, otherwise she's intact. This patient has a type 3 odontoid fracture and also has, as you can see here, Hangman's fracture. The MRI shows significant posterior ligamentous injury, as you can see. And this patient ended up having this procedure here, C1 to C4 fixation. So that was the procedure that we performed. And then there's the Hangman's fractures. There's type 1 here. You can see you have a fracture through the pars of C2. However, the lines are parallel. There's a type 1A where it's going to be similar, except the fracture lines will not be parallel. Then there's type 2. Once you get to type 2 and above, these are going to be the unstable ones. With type 2, you start having disc disruption at the C2-3, and you can see here in the type 2, this patient is starting to have a little bit of listhesis and angulation. Then at the type 2A, the angulation is greater than 11 degrees. And then type 3, now we start having facet dislocation as well. So most of these can be managed with external immobilization, and surgery is considered for the type 2 and type 3. Where you have severe angulation of C2 and C3, there's disruption of the C2-3 disc space, and there's also surgical candidates would be those who you've tried the external immobilization, but they failed. So the surgical options will be a C2-3. You can do a C2-3 ACDF, and the benefit of this is that it will preserve motion. And you can also do C1 to 3 posterior instrumented fusion. Now, if the disc, again, if the C2-3 disc is intact, then you can do a C1, C2 fusion. But if that disc is disrupted, I would say probably the best procedure for this would be an ACDF, as you will preserve a significant amount of motion. These are things that I already went through. So it was just a summary. I'm going to skip some of those. Here is a quick video that we're going to play for you. This patient, pay attention to the C1, C2 dislocation. You're going to see it here first on this coronal view. We're going to keep going here. And look at where you're going to see where the odontoid process is. Look at how far the odontoid process is from where the C2 lateral masses are. So we have a significant dislocation at C1, C2 with translation laterally. And we can go ahead and play the next video. Go slow. And you see the odontoid process was over that facet, and then everything is translated so far laterally. So pretty significant dislocation at C1, 2 here. and just one more time on the CT scan on the left, the CT on the left. That way, the MRI won't be as helpful. So I'm going to skip the MRI on the next slide, and we'll just move on to the discussion here. So again, look where the odontoid process. Look at the translation that we have there. All right. So next, move on. So patient has occlusion of bilateral vertebral arteries. I'll skip that. That was the MRI. We went to the operating room. I put a few weights to reduce it, and there you can see intraoperatively. Again, we used stealth navigation. The fracture is reduced very well, and we did C1 to 5. Let's see here, 2, 3, C1 to C5 fixation, and the patient did really well. Obviously, there was a significant translations, and patient's bone wasn't of best quality, so we have multiple fixation points to help with that, and this really long, strong C1 screws. Real quick, I'll go through some neurotrauma and critical care of the brain. We'll just go. Now, this is going to be a quick summary. The most common cause of TBI-related deaths in patients greater than 75 and less than 75. So in patients greater than 75, it's going to be falls. In patients less than 75, it's going to be motor vehicle accidents. You have a 36-year-old who presents to the emergency department after MVC. He's evaluated in the emergency department by neurosurgery and found to be opening his eyes only to sternal rub, making incomprehensible sounds, and briskly withdraws with his right upper but does not move the left upper extremity. What is the next step of action? The key here to determine is, the patient's GCS is 8. So the first thing you want to do is get these patients intubated. And how do we classify TBIs? If they're GCS 3 to 8, that's going to be severe. 9 to 12 is moderate, and 13 to 15 is mild. And then where do you localize the lesion, and what's the next step? A patient, because of their left weakness, patient has it's localized to the right cerebral hemisphere, and a CT of the head is obtained. So we have a large subdural, and the patient was taken to the operating room for an evacuation. And here we have a 48-year-old nurse who presents to the hospital after a fall down a flight of stairs at work. She opens her eyes spontaneously. She's confused, follows commands. What's the GCS? Again, this is a GCS 14, who is, so we would classify this as a mild TBI. The CT findings, you'll see some subarachnoid hemorrhage, you'll see interventricular hemorrhage, you'll see some small petechial parenchymal hematomas. And what are the chances that she will be unemployed at 3 months and at 12 months? This is interesting. So mild TBI survivors have a high unemployment rate of 34% at 3 months and 9% at 12 months. So just something to keep in mind with all these traumas that we see. I'm going to stop there, and we maybe have time only for one question.
Yeah, very good. Thank you. Dr. Ogutu in Germany is asking the question, what's your experience with C1-2 screw loosening or implant failure in a young and older population?
Yeah, so
especially for the Harms procedure.
For the Harms procedure, it does happen. So the key, what I do in my practice, Dr. Ogutu, is that I will keep these patients in a collar. Okay, I arthrodese, and I keep them in a collar. Every patient, even after screw fixation, I want to limit that rotation. If you do this fixation, and all the patients will tend to want to still rotate their heads. So what happens is those screws start loosening, especially that C1 will start really, digging into, will really start creating a channel in that bone. And you want to make sure those screws are bicortical. So 2 things, make sure your screws are bicortical, and then keep the patients in a collar. I keep them in a collar for C1, C2 screws. Everybody stays in a collar for at least 4 to 6 weeks.
Very good, thank you. And we'll move on to the next presentation with Bethwell, if you'd like to.
Supplement to that, what I often do with those cases is a modified Sontag wiring with a piece of bone in between C1, C2, because that really gives you a nice bone mass so that not only are you fusing the facets, but you're getting a nice fusion dorsally. I think that the screws themselves alone can fail if fusion doesn't occur, and this is a nice way to supplement that.
That's an excellent point. A structural allograft could be used as well. Very good.
Yep.
All right, Dr. Awuor, if you'd like to introduce the next presenter.